Hello, this is Dr. Jonathan Meyer, Voluntary Clinical Professor of Psychiatry at the University of California, San Diego, here to talk about lithium's drug interactions. All of this relates to how lithium moves through the kidney. We talked in lithium's renal journey about the fact that lithium is filtered proximally in the glomerulus and it competes with sodium for reabsorption. Well, that can relate to one of the issues we see with lithium, which is not a drug interaction per se, but something you should educate patients about. If they become sodium depleted, either through GI losses or excessive sweating, they should always replace this with an electrolyte solution with salt in it and not just free water. That's how people get into problems. They deplete themselves of sodium, they replete themselves with just free water, they become now hyponatremic, and this can induce lithium toxicity. But most of the other issues relate to generally antihypertensive agents and where they interact with lithium. Most of these are manageable as long as you know about them. And as we'll discuss, an important aspect of patient education is that when you are starting on a new medication, you let me know immediately. It would be nice if the other provider starting the antihypertensive would let you know, but you cannot count on that. Here are the drug interactions broken down by the site of action of the various agents. So let's start in the upper left. ACE inhibitors and ARBs. These impact renal blood flow, and in general, this is a manageable interaction. We know that lithium levels go up about a third, 36%. So why, if it's only 36%, are there case reports of toxicity? Because people did not make the downward adjustment on the lithium dose when the ACE inhibitor or the angiotensin receptor blocker were added. All of those agents are generally safe with lithium with one exception, and that's lisinopril. Lisinopril is the only ACE inhibitor which is 100% renally cleared. It tends to accumulate, especially in people who may have subnormal renal function. If you have a patient you want to start on lithium who's on lisinopril, just ask the PCP to pick another ACE inhibitor. And if lisinopril is added to your patient on lithium, it's not like they're going to die from this. You have time to make the adjustment of the dose and then ask the provider to try to switch to another ACE inhibitor. Nonsteroidals, I think, are an area of big confusion. These also alter renal hemodynamics, and that's how they alter lithium clearance. The big issue is whether it's going to be chronic use, whether the person has baseline low GFR, and of course, if their baseline lithium level is high or low. One thing we've come to appreciate is that relatively infrequent use or use less than a week of the 5 days in people with GFRs above 75 and whose lithium levels are below 0.8, unlikely to cause a clinically significant problem. But as you have more of those risk factors, meaning GFRs below 75, lithium levels are zero point 0.8 or higher, and the nonsteroidal use is certainly going to be chronic, this can cause toxicity and you need to make adjustments. Again, this is a point of education with the patient and also knowing which patients may run into problems. But I think for any human being, if it's going to be chronic use, 5 days or more, you want to let them know we may need to make an adjustment to your lithium use to lower the dose just enough to mitigate lithium toxicity. And certainly if they have high levels, you know, 0.9 and the GFR is 65, this is a big deal. And you really have to educate people about avoiding nonsteroidals, avoiding them chronically. If they have to do them, they're going to give you a call and you're going to make some adjustments to the lithium dosing. Typically just reducing it by 25%. And as long as they stay on the nonsteroidal, you'll monitor periodically and make the appropriate adjustments based on the level. We've talked about in a prior episode how to manage polyuria, and one of the adjunctive agents we'll use are carbonic anhydrase inhibitors like acetazolamide. This is the one class of medications which actually lowers lithium levels. We don't use it too often, but if a milliride is not enough to manage the polyuria, we will add acetazolamide onto it. Thiazide diuretics are commonly used out there. They will increase lithium levels, mostly due to their sodium wasting. Again, if you don't make the adjustment in the lithium dose and the level, you may have toxicity. Once somebody's put on a thiazide, you make the adjustment and you follow them up. It's a manageable problem. The potassium-sparing diuretics do not have significant impacts on lithium level. In fact, one of them, amiloride, we actually use to manage polyuria. And then lastly, among the loop diuretics, you have to consider who's getting the drug. We know there's an impact on lithium clearance, but on average it's only about 11%. But most of those studies were done in young, relatively healthy people. But we know that when you give furosemide, for example, to elderly individuals above the age of 65, you can cause lithium toxicity. They become very volume contracted and sodium wasted. The point being, if you have somebody who's going to be chronically on a loop diuretic, make the appropriate adjustment in their dose initially, and then you can follow up their level and adjust based upon the subsequent level, especially for older individuals. There's an odd interaction out there with a non-antihypertensive. It has to do with the sodium glucose cotransporter inhibitors. These are called gliflozins. A bunch of them out there, very effective. They reduce mortality, they reduce heart failure risk. They're wonderful drugs. But we have case reports of people being on these drugs and driving down their lithium levels substantially, meaning 63% in one instance. If somebody gets started on one of these gliflozins, you need to know immediately so that you can recheck their level and adjust the dose. You're probably going to end up having to double the dose, maybe even more, but just educate the patient. This drug is causing you to clear your lithium more quickly. We'll adjust the dose to keep your level where it needs to be. Again, education is the key. Let the patient know that if new medicines are added, not every medicine, but there's certain classes of medicines. You can give them a list and say, if you're not sure, you can always give me a call. But things which impact renal blood flow, like nonsteroidals, ACE inhibitors, ARBs, certain diuretics, SGLT2 inhibitors, the gliflozins, you want to know right away, and you'll make the appropriate adjustments. Again, nonsteroidals is a nuanced decision based upon the patient's renal function, their levels, and how long they plan on using it. It would be nice if other providers would clue you in when they're starting agents that interact with lithium, but you cannot rely on this. It would be nice and it's wonderful when it happens, but certainly you cannot rely on this. And this is why talking with your patient, giving them examples of medicines you're concerned about can be very, very helpful. But once you know about an interaction, do the appropriate adjustment. Whether this is a new drug added to lithium, which is going to boost levels, and then you'll make the downward adjustment in lithium dosing and then recheck the level, or maybe they were on a drug which was boosting lithium levels and now it's been withdrawn. Either way, when there's a change, typically we will anticipate what will happen to the lithium level, make the dose change, get a level in about a week, and then follow up everything based upon the level. And here's some tables from a book on lithium, just going over what I talked about. Again, there's concerns really when something is added to the lithium that it may bump up the level, for example, the ACE inhibitors or the ARBs. Once you know about it, you can make the appropriate adjustment to the lithium dose and then check the level again. Or if you're starting lithium somebody, for example, who is on an ACE inhibitor or an ARB, you know that their levels are going to be higher than you would expect. And so your initial dose might be a third lower. But again, all the follow-up is going to be based on levels. The most important thing is anticipate the interaction, make the appropriate adjustment to the lithium dosing, and then follow it up based on levels. So ACE inhibitors and ARBs, similar interactions, similar monitoring. As I said, the only agent in these class, or both of them, which you can't use is lisinopril because it is 100% renally cleared. Calcium channel blockers, no significant interactions. Carbonic anhydrase inhibitors, acetazolamide, I said it's one of the few agents which lowers lithium levels. You'll make the appropriate adjustment based upon the new level and adjust the dose. Loop diuretics, again, the big concern is older individuals with subnormal renal function. They can really become volume contracted and lithium toxic. You're going to have to adjust the lithium dose in those people when it's added to lithium. If you have a younger person, maybe you'll just recheck the lithium level and you'll need to do nothing. Again, if you're adding lithium to people who are already on loop diuretic, just consider who the person is and your just initial dosing based upon that, with all subsequent dosing again based on the lithium level. Potassium-sparing diuretics, no significant impact on lithium levels. Thiazides, though, do. They cause more sodium wasting. Again, anticipate the interaction, make the appropriate adjustment, and then follow up based upon the new lithium level. Non-steroidals, again, I've already given you some discussion about the extent of exposure, the chronicity of the exposure, whether the person's baseline levels are on the high end and whether their baseline GFR is on the low end. These are the variables. It's important that you simply educate people, that you don't make them fearful. You say, look, short-term use, especially if this individual has excellent renal function and their lithium level is, below 0.8, you probably don't have to worry too much. But as they're going to use them chronically, you want to give them some guidance on what to do. And that's really all you want to do. You don't have to scare people. Non-steroidals can be used. You just have to do some monitoring if they're going to be used chronically, especially in people who have subnormal renal function or high levels. The SGLT2 inhibitors, the gliflozins, again, they may drive levels down quite a bit. So if somebody gets put on one of these agents, check the level. It's going to be low. You'll make the dose adjustments, and then you'll recheck the level again in a week on lithium. And then there's these weird case reports of flagyl, metronidazole. We don't know what the mechanism is. We think this actually may not be a kinetic issue, but there's these unusual interactions. If people experience CNS adverse effects, if they're on this combination, just tell them to stop it. I mean, these cases are really rare. There's only 3 in the literature. We don't know what the mechanism is, but most importantly, you just let people know if you feel weird while you're on this combination, you stop it and let the provider know who prescribed the flagyl for you, that they need to pick something else.